8 early warning signs of sepsis that could save a life before it's too late. Every year, sepsis claims more lives than breast cancer, prostate cancer, and AIDS combined. Yet most people have never heard of it until it strikes someone they love. Sepsis is a life-threatening condition that develops when the body's response to infection goes out of control, causing widespread inflammation and organ damage. Early recognition of its often subtle, combined symptoms can be the difference between recovery and tragedy. Understanding sepsis means understanding urgency. Every hour matters. What begins as a manageable infection can quickly become a life-threatening, body-wide crisis, where organs fail and the body struggles to keep up. Sepsis is especially dangerous because it can affect anyone and is often unrecognized. Many people don't know the warning signs, delaying urgent treatment like antibiotics and fluids, delays that can be fatal. Today, we're breaking down each of these 8 warning signs. You'll learn exactly what they look like, why they happen, and most importantly, what to do when you spot them. Because when it comes to sepsis, recognizing these signs within the first hour can mean the difference between life and death. Disclaimer: this content is for informational and educational purposes only and is not intended as medical advice. Sepsis is a serious, life-threatening condition that requires immediate medical attention. Seek emergency medical care right away. Always consult a qualified healthcare professional for diagnosis and treatment. All information presented has been thoroughly researched and verified. You can find source links in the video description. 1. Confusion and altered mental state. The brain is often the first organ to signal that sepsis is developing. A sudden change in mental status, confusion, disorientation, or slurred speech should trigger immediate alarm bells. This isn't someone being a bit forgetful. We're talking about a person who was completely normal this morning, but now can't tell you what day it is or where they are. They might struggle to complete sentences or seem drunk, despite having consumed no alcohol. The medical term is sepsis-associated encephalopathy, or SAE. It occurs when inflammatory chemicals released during infection begin breaking down the blood-brain barrier, your brain's protective shield against toxins. Once this barrier weakens, inflammatory molecules flood into brain tissue. They activate the brain's immune cells called microglia, which then release neurotoxic substances. This creates a vicious cycle of inflammation that disrupts normal neural signaling. Blood pressure drops during sepsis also starve the brain of oxygen. The regions controlling speech, memory, and executive function start failing. This is why patients exhibit that characteristic drunk-like behavior, slurred words, poor coordination, impaired judgment. Healthcare providers use the Glasgow Coma Scale to quantify this. A score below 15 indicates something is seriously wrong. But you don't need medical training to recognize the problem. If your loved one went from normal to confused within hours, especially if they have an infection, sepsis must be considered. In elderly patients with urinary tract infections, confusion might be the only symptom. Don't dismiss it as just getting older. This mental change happens because your brain is literally being poisoned by the inflammatory cascade. It's reversible if caught early, but permanent brain damage occurs if treatment is delayed. 2. Extreme difficulty breathing. Rapid, shallow breathing, medically termed tachypnea, is one of the earliest measurable signs of sepsis. If someone is taking more than 22 breaths per minute at rest, their body is in crisis mode. Count the breaths for a full minute. Normal adults take 12 to 18 breaths per minute. In sepsis, you might count 30, 35, or even 40 breaths as the body desperately tries to compensate. Here's what's happening internally. Sepsis triggers anaerobic metabolism. Cells switch to an inefficient energy production method that floods the bloodstream with lactic acid. This creates metabolic acidosis, dropping blood pH to dangerous levels. The brain's respiratory center detects this acidosis and commands faster breathing. The goal is to blow off carbon dioxide, which helps neutralize the acid. But this compensation strategy has limits. Meanwhile, inflammatory mediators are directly damaging lung tissue. The tiny blood vessels in the lungs become leaky, allowing fluid to seep into the air sacs where oxygen exchange happens. This pulmonary edema makes every breath less effective. Patients describe it as air hunger, an overwhelming sensation that they can't get enough oxygen no matter how hard they try. You might hear grunting sounds with each breath, especially in children. You might see the muscles between the ribs pulling inward with each breath, a sign called intercostal retractions. If left untreated, this progresses to acute respiratory distress syndrome, or ARDS. The lungs fill with fluid, appearing completely white on chest X-rays. Patients require mechanical ventilation because their lungs can no longer sustain life. In elderly patients, rapid breathing might be the only visible warning sign. 3. Racing heart and plummeting blood pressure. Your heart rate and blood pressure tell a critical story during sepsis. A heart rate exceeding 90 beats per minute combined with a systolic blood pressure below 100 millimeters of mercury signals cardiovascular collapse. Initially, the heart races to compensate. Inflammatory chemicals cause widespread blood vessel dilation. Your arteries and veins essentially become too wide. To maintain blood flow to vital organs, your heart beats faster and harder, driven by a massive surge of adrenaline. This is why patients feel their heart pounding out of their chest. Some describe it as a jackhammer in my rib cage. The pulse becomes rapid and thready. You can feel it racing under the skin, but it's weak and easily compressed. However, this compensation has limits. The heart muscle itself becomes a victim of the inflammatory cascade. Cytokines like tumor necrosis factor directly depress heart function, reducing the force of each contraction. The heart dilates and weakens even as it's being forced to work harder. Blood pressure begins dropping despite the racing heart. This is the transition into septic shock, a medical emergency with mortality rates exceeding 40%. Blood pressure falls below 90/60ths millimeter of mercury, and in severe cases, drops to 70/40ths or lower. The pulse pressure, the difference between systolic and diastolic numbers, provides additional clues. Early on, it widens as diastolic pressure drops faster than systolic. This warm shock phase features bounding pulses and warm, flushed skin. As shock progresses, the pulse pressure narrows. Both numbers fall together, signaling the heart is failing. The extremities turn cold and clammy. Nail beds become pale or blue. 4. Fever or dangerously low body temperature. Temperature abnormalities are classic sepsis indicators, but both extremes are dangerous. A fever above 100.4 degrees Fahrenheit or hypothermia below 96.8 degrees Fahrenheit in someone with suspected infection demands immediate evaluation. High fever is what most people expect. Inflammatory chemicals reset your hypothalamus, your body's thermostat, to a higher set point. Your brain genuinely believes your body temperature should be 103 degrees Fahrenheit, so it triggers intense shivering called rigors to generate heat. These aren't normal shivers. Rigors are violent, teeth-chattering episodes where the entire body shakes uncontrollably. Patients often require multiple blankets, yet still feel frozen. This is your body creating heat through rapid muscle contractions. But here's what surprises people. Low body temperature is actually more dangerous. Hypothermia in the context of infection signals immune system failure. Your body has exhausted its metabolic reserves and can no longer mount a proper inflammatory response. This cold sepsis is particularly common in two populations. Newborns lack the metabolic machinery to generate fever efficiently. Their immature immune systems respond to infection by dropping body temperature instead. Elderly patients present a different challenge. Their baseline temperature often runs lower than the standard 98.6 degrees Fahrenheit, sometimes only 97 degrees Fahrenheit. So a temperature of 99 degrees Fahrenheit might actually represent a significant fever for them, yet it appears normal on the thermometer. This is why geriatricians emphasize knowing each patient's individual baseline. A nursing home resident whose temperature suddenly rises from 97 degrees Fahrenheit to 99.5 degrees Fahrenheit may be just as sick as someone spiking 103 degrees Fahrenheit. Temperature extremes reflect the chaos unfolding at the cellular level. 5. Mottled, discolored skin. The skin provides a real-time window into your circulation. In sepsis, a distinctive purple, lace-like pattern called mottling appears on the skin, most commonly starting at the knees. This isn't bruising or a rash. Mottled skin looks like irregularly shaped purple patches forming a net-like pattern across the knees, thighs, or other areas. The pattern occurs because small blood vessels are constricting unevenly, creating areas of poor blood flow right next to areas of normal flow. Medical teams use the mottling score to quantify severity. Mottling only on the knees scores 1 point. Extension to the mid-thigh earns 2 points. When it reaches the groin, that's 3 points. Mottling extending beyond the groin scores 4 points. Higher scores correlate directly with increased mortality risk. The underlying problem is microcirculatory failure. Even when doctors restore blood pressure with fluids and medications, the tiny capillaries remain severely impaired. They can't deliver oxygen to tissues effectively, leading to these visible perfusion defects. Another critical skin sign is petechiae, small red or purple dots that don't blanch when you press on them. These represent tiny hemorrhages under the skin caused by disseminated intravascular coagulation, or DAC. In DAC, the clotting system activates throughout the body simultaneously. Microscopic clots form in small vessels, consuming clotting factors faster than the liver can produce them. Eventually, vessels start bleeding spontaneously because there's nothing left to stop the bleeding. For patients with darker skin tones, these changes are harder to detect on the arms and legs. Check the palms, soles of the feet, and the inside of the mouth and lips instead. 6. Decreased or no urine output. The kidneys are exquisitely sensitive to sepsis. When someone hasn't urinated in 12 to 18 hours, or their urine becomes dark brown or tea-colored, acute kidney injury is likely developing. Oliguria, the medical term for decreased urine output, occurs in 50 to 70% of intensive care patients with sepsis. It's not just a symptom, it's an independent predictor of death. Patients who develop kidney failure during sepsis have mortality rates exceeding 60%. The traditional explanation blamed decreased blood flow to the kidneys. But recent research reveals a more complex mechanism. Sepsis triggers inflammatory signaling that directly damages the tubular cells responsible for filtering blood and concentrating urine. Specifically, nitric oxide produced in the kidney's medulla inactivates a transcription factor called TUN-EBP. This transcription factor normally maintains expression of aquaporin, 2, the water channel that allows kidneys to concentrate urine. Without it, kidneys lose their concentrating ability. Additionally, inflammatory cytokines and bacterial toxins filtered through the glomeruli cause direct tubular cell death. The cells that survive undergo metabolic reprogramming, switching to a survival mode that impairs normal kidney function. For patients whose sepsis originated from a urinary tract infection, called urosepsis, the kidney damage is even more direct. Bacteria ascending from the bladder into the kidneys cause pyelonephritis, an infection of the kidney tissue itself. Watch for these additional urosepsis signs: severe flank pain, pain when urinating, blood in the urine, and tenderness over the lower back or just above the pubic bone. Dark brown or tea-colored urine suggests rhabdomyolysis, muscle breakdown releasing myoglobin, which is directly toxic to kidney tubules. 7. Severe muscle pain and weakness. Sepsis survivors consistently describe excruciating muscle pain as an early warning sign. Many report it as the worst pain of my life, or feeling like they've been hit by a truck. This isn't typical aches and pains. We're describing deep, whole-body muscle pain that makes even small movements agonizing. Patients struggle to lift their arms, turn over in bed, or even hold up their head. The mechanism is cytokine-driven muscle wasting. Inflammatory chemicals activate proteolytic pathways, specifically the ubiquitin proteasome system and autophagy pathways, that rapidly break down muscle proteins. Your body is essentially cannibalizing its own muscle tissue. The amino acids released are diverted to the liver to produce acute phase proteins needed for the immune response. But this comes at a devastating cost. Skeletal muscle mass can decrease by 10 to 15% within just the first week of severe sepsis. This acute muscle loss exceeds what occurs during prolonged bed rest or even starvation. The preferential loss occurs in fast-twitch muscle fibers responsible for strength and power. In extreme cases, this progresses to rhabdomyolysis, wholesale destruction of muscle tissue. The breakdown products, particularly myoglobin, spill into the bloodstream at toxic concentrations. Myoglobin turns the urine dark brown, resembling tea or cola. When filtered through the kidneys, myoglobin crystallizes inside the tubules, causing direct tubular necrosis and acute kidney failure. The combination of sepsis-induced kidney injury plus myoglobin toxicity creates a particularly lethal scenario. Survivors often require months of physical rehabilitation to regain lost muscle mass and strength. 8. An overwhelming sense of doom. Perhaps the most haunting warning sign is purely subjective, the patient's conviction that they are about to die. When someone with suspected infection states, "I feel like I'm going to die," experienced clinicians take this with utmost seriousness. This isn't anxiety or hypochondria. It's the conscious mind's interpretation of catastrophic physiological failure signals that the body can detect but cannot articulate in any other way. The neurophysiological basis likely involves severe hypoxia combined with catecholamine surge. The brain integrates information from chemoreceptors detecting low oxygen, baroreceptors sensing dropping blood pressure, and inflammatory mediators crossing into brain tissue. This creates what one researcher described as a cerebral crisis alarm. The amygdala, your brain's fear center, activates maximally. The anterior cingulate cortex, which processes physical pain and emotional distress, lights up on functional imaging. Simultaneously, the massive release of adrenaline and noradrenaline triggers the full fight-or-flight response. Heart rate skyrockets. Pupils dilate. Breathing accelerates. The body is screaming danger at the maximum volume possible. But here's the problem. Septic patients are often too weak to fight or flee. They're confined to a bed, unable to act on these overwhelming survival impulses. The mismatch between the body's screaming alarm signals and the inability to respond manifests as existential dread. Patients describe feeling detached from reality, like they're watching themselves from outside their body. They report absolute certainty of impending death despite medical reassurance. When this symptom appears alongside other warning signs, rapid breathing, confusion, racing heart, it demands immediate emergency evaluation. The patient's subjective experience is often more accurate than objective measurements. Subscribe to the Human Health YouTube channel for more insights. If you found this content helpful, please like, share, and comment below.